All right. It is 8:45 and we're going to try to stay on time. Do we have our off-site debaters are present? Awesome, perfect. So thank you for being here. For those of you who don't know me, I'm Dan Dent from UT Health San Antonio, and I'm going to be moderating the first debate. I thought about going with my professional wrestling voice and introducing the two opponents and their heights and weights and everything else, but I'll keep that to a minimum and keep this in a more professional decorum. But I will introduce both of our debaters here at the beginning. On the pro side of the question of general surgery subspecialists should be required to take call, we've got Dan Margulies, who is from Los Angeles, a very accomplished surgeon who the short version of his CV is he's a past president of this organization and all that comes with that. And on the con side, we've got Walter Biffle from San Diego. And the short summary of his CV is that he's the treasurer of this organization and all that comes with that. And so I won't go into too much detail to give them plenty of time to speak. So first up, we have Dr. Margulies.
Thanks, Dan. I'm going to be fairly brief. I'm going to talk about the pro side of should specialists take general surgery call. And I'll basically be giving you my opinion. I'm going to give you a little data. For instance, this was an article back in 2004, but it pointed out the big problem that emergency departments are seeing across the country, which is that they can't get surgical specialists to come in. And this was across the board, orthopedics and neurosurgery. But in particular, it also involved the general surgeon. And yet we have general surgeons all across the country, quite a few. And so why is that? Well, it was a little different in the different types of institutions. Universities, they still had problems, but community was the worst. The universities, I guess, had people on call to teach and residents, but community hospitals really had a big problem of getting the specialists to come in. This led to having to pay people to take call, and essentially it paralleled what the phenomenon that all of you are familiar with, which is that the general surgery resident felt they had to do fellowships, go into fellowships, and then they specialized and they were doing breast and all these other specialties and not taking general surgery call. So this article back in 2004, summarized that surgical specialists are the most problematic of all the on-call physicians that they were having to deal with. And the on-call, this is a direct quote, the on-call situation in California has reached crisis proportions. And there's a lot of data since then that things haven't gotten better. In fact, they've gotten worse. I'm not going to go through a lot of articles. I don't want to bore you with them, but essentially you're all familiar with that problem. We need general surgeons to take call. Now, so we know the problem. They're not available. And there's a shortage of coverage for surgical specialists. So this is known. But what are the solutions to that? Well, in particular, there's this huge need for the specialists to take a call all across the country. The solutions are, we could train more general surgeons that aren't specializing. That would be one solution. And the other is to have the specialists that have all been trained in general surgery to just participate in the call. So which way do we want to go? Well, the first way, training more general surgeons, that's a massive effort. I mean, how would we do that? It would definitely be expensive. It would take years to effect. And then the majority do specialize anyway, reducing the pool of available non-specialized general surgeons. So that's very problematic. And I'll just give you my opinion. That's not going to be a solution that's viable. How about having the specialists who are already trained to take general surgery call actually take general surgery call? Well, we know they've done 5, 6, 7 years of general surgery. They are fully capable and trained in general surgery by the time they finish. You know, you think about the chief residents that you work with, you know, they've been doing so many gallbladders and appendectomies and, you know, that, yes, they may go into another field, but when they're done, they are trained, they've passed their boards, they're qualified by the American Board of Surgery to take all sorts of general surgery call. In fact, that's why we call them general surgeons. Now, if each of them were to do their share of call, it does spread the need amongst the many, and it really makes the amount of call that any one person or one, you know, individual has to do, and it shares the pain, so to speak, of the call across a large number, all the qualified general surgeons, as opposed to what we've really gotten into, which is that we've forced it to the ACS surgeon, who's a trauma surgeon in-house, making them do everything. And they each went to medical school, and just as a reminder, for a reason, and the reason is generally to help people, not necessarily to do their one specialized thing, but to help people. And this is one way that they could do that. Let them fulfill the purpose of which they originally went into surgery for. So that first role, potential solution, not good. That second solution, have the specialist take general surgery call. There are many, many reasons to do this, and I've outlined a few. And my other surgeon that's going to be discussing the con here will tell you things like, this is Dr. Biffle, he's going to tell you things like, well, do you really want a breast surgeon taking your gallbladder out if you have to have it out, or your appendix out? And, you know, he may say that, I don't know, but he may say that. Or some other inflammatory fear-mongering statement such as that. But again, in reality, all trained surgeons can take care of emergencies. That's really all we're asking. Take care of the emergency. It's kind of like, you know, if you have to have pus drained, do they know how to do that? Yes. Okay. And then the next day, things can be given to the team that specializes in whatever field that is. So the non-life-threatening diagnoses can be left to the daytime general surgery staff. Gallbladders that don't have to go at night can be, you know, admitted, evaluated, and given to the daytime team. This is a model that works. And then complex and devastating cases that, you know, they don't all have to be completed. We've learned this as well in trauma surgery and general surgery, that damage control can be standardized. You basically have to take care of the big problem, save the patient's life, and you can leave the abdomen open if you're not comfortable with doing everything. And then again, the team that comes in the daytime can do that. So that they can take care of the main problem. And this is known. So again, all trained general surgeons can do this. Now, getting back to that question of, do you want a breast surgeon doing your surgery? Maybe not if they've been doing breast surgery alone for 20 years and they have forgotten how to do these things. So it's important, I think, that we institute this from the get-go after residency. Don't let them get out of practice. But if it's another reason that we could increase the pool of participants by letting them take call very soon after they finish. So what are the specialists that we're talking about? Well, we have vascular, colorectal, surg-onc, breast, endocrine, minimally invasive, and trauma ACS. These are the specialties of general surgery. These were not only trained to know and how to take care of the general surgery issues, they can actually offer some exceedingly good care that their extra training has provided. So when you get a colon in the middle of the night and you're a colon surgeon, you actually get somebody that's even more expert. And or another example is the minimally invasive surgeon prime example of applying the minimally invasive techniques that maybe somebody not quite as expert wouldn't. And so when we put Dr. Kotari on call, he actually can do an amazing job of doing something minimally invasive that somebody else might not. So it's kind of a additional benefit that many don't think about. Another example is surgical oncology. They have extra training in the complex cases, and they come in and take care of a perforated, gastric cancer. That's going to add some additional expertise. As similarly, colon and endocrine, these relevant cases may present themselves in the middle of the night. And again, the trauma ACS already are in-house taking call, so they're already doing the general surgery call. So it's a matter of involving these others who were trained to allow them to fulfill what they spent years training. Now, some may argue that the night call interferes with their elective practice, and my colleague may argue that as well. And that is true. To have to do your elective practice after a night of call is a bit of a problem, but it's all the more reason to spread it out and not have it concentrated to those few. You spread it out and the impact on any one individual is much lessened to a great degree. And if they really argue, put them on call on Friday or Saturday where their practice is not actually happening the next day. A further argument is that if these folks, if they do stay active in general surgery, again, they're going to lose, if they don't stay active in general surgery, they're going to lose their skills and their knowledge, which they spent a long time learning. And by keeping them involved, they maintain these skills. So again, start right after training is over. And I am just giving you my take and a plea that we get back to having general surgery remain general surgery. Why do they train in general surgery if not to provide it at least some of it at a time? So the age of fragmentation, in my view, it should end. If we don't reverse this trend, we're going to dig ourselves an ever deeper hole. So I'm going to stop there and let the other side speak. Thank you.
Dr. Biffle, your reply?
Aloha and greetings from the mainland. This morning, I'm going to be explaining why general surgical subspecialists should not be required to take general surgery call. I have no conflicts of interest to disclose. The reason we're here this morning is because there's a crisis in access to emergency surgical care in the US. This has been going on for many years, as highlighted in the Institute of Medicine report in 2007. Now, two major factors contributing to this problem are listed here. First, the general surgery workforce has been shrinking while the population in need grows. An AAMC report from 2015 predicted that by 2025, there would be a shortage of 27 to 35,000 general surgeons. At the same time, more and more general surgery residents are pursuing subspecialty training. Over a third of them enter non-general surgery practices such as pediatric, plastic, thoracic, and vascular. Now, one potential solution to this shortage is that general surgery subspecialists can and should fill the void. You see that of these 64% that go into general surgery related subspecialties, many are familiar with operating in the abdomen, including MIS and bariatric surgeons, colorectal, surgical oncologists, HPB, advanced GI, and those who enter surgical critical care. Now, these excellent surgeons can do anything, but just because you can do something doesn't mean you should. Is this really a good idea? Is this the best way to put out a fire? Is it the best way to give your cat a bath? Now, I feel bad for my friend and colleague, Dr. Margulies. He's easygoing and he gamely took on the losing side of this debate and put together an argument, but he knows that EGS is a real specialty. It's challenging. 80% of the procedures done on general surgery call are listed here: laparotomies, lysis of adhesions, colectomy, small bowel resection, appendectomy, cholecystectomy, peptic ulcer disease repairs, and of course the pus cases. All right, well, admit that this is a lot of taking out necrotic organs and draining pus. And a lot of you in the audience are probably saying, oh, it's just bread and butter general surgery. What's the big deal? You're probably the people who are taking surgery call. But there are probably some of you out there who are squirming a little bit, saying, I'm glad I don't have to do any of that stuff ever again. I think you're who we're talking about. About 15 years ago, I was in Rhode Island, ran into a former patient of mine in an Italian market. And he had had an emergency thoracotomy. We talked about how he was doing, he's back at work. He said, hey, doc, I never talked to you much about your job and what you do. Are you a thoracic surgeon? I said, no, I do a little of everything. He says, oh, jack of all trades. I said, yeah, I guess so. That's what I try to do. Well, a few years after that, I met President-elect Qatari. We had a similar conversation. And when he said it, it didn't sound so flattering, but I know my truth. And I aspire to be the type of surgeon that Halstead alluded to here. When he talks about surgeons who are well and able to deal with any emergency that may arise. Now, the concept of such a surgeon is at the heart of the acute care surgery transition, trauma surgeons, and fragmentation has made it more difficult for surgeons to maintain that kind of stature and that comfort level with anything. But we do try. Now, if you talk to your subspecialist colleagues, you may hear a number of reasons why they can't or don't want to take general surgery call. We're too busy during the day. We're asked to go to all the outlying clinics, so we're never at the home hospital anymore during the day. It's disruptive during the day. We can't get patients into the OR during the day. What if we need to operate on them the next day? Remind them that there is a nighttime. Well, acute care surgery is the standard everywhere now. How can we recruit more specialists to work here if the specialists have to take call? We're not all comfortable with that. That notion of being comfortable was addressed by Dr. Jurkovich in his Scudder oration on trauma last fall. And this is certainly relevant to the topic at hand. What does it mean when somebody says they're not comfortable with this? What does it reflect? Jurkovich discussed issues and gaps in training, competence, confidence, autonomy, and sadly, professionalism and ethics. He reviewed a paper from the American Surgical Association, which surveyed program directors of the Fellowship Council. 21% believe that new fellows were unprepared for the OR. 38% demonstrated a lack of patient ownership. 30% couldn't autonomously perform a lap chole. And 2/3 were deemed unable to operate unsupervised for 30 minutes during a major procedure. They also identified deficits in operative autonomy, progressive responsibility, longitudinal follow-up, and scholarly focus after general surgery training. These are surgeons who have just finished a general surgery residency, and now they're going into subspecialty training that will take them further away from the ability to do that broad base of operations. But let's not talk about the surgeons at this point. It's about the patients. And the stakes are high in emergency general surgery. This study from the NISQIP database looked at over 1 million operations by general surgeons. 15% of the operations were done in emergency surgery patients, but they accounted for 54% of the mortality. Another study from the NISQIP database looked at 14 procedures that were common to emergency and non-emergency situations for general and vascular surgeons. 36% of the cases were emergencies. The mortality in these cases was 5-fold higher than in the non-emergencies, and the major complication rate nearly 3-fold higher. However, this is about the patients, and EGS requires skills and expertise. The patient does not benefit from a surgeon who's standing at the bedside, not knowing whether to scratch their head or their nether regions. Volume matters in EGS just like in other specialties. In this study, low volume surgeons were those who did fewer than 25 complex EGS cases in a year, the mortality rate was significantly higher for their patients. This picture does not need any caption. I pick on Qatari because every time I'm on trauma call, he's sending a picture of a big steak and a bottle of wine and his wife and a view from their lake house. And I send back a picture of my steamed fish and mixed veg. And I wonder why he never takes call. But imagine if he did. He'd have to leave his wife, go into the hospital and see this. And what's going to happen? I shudder to think. Now, the subspecialist surgeons aren't completely useless. There are some data suggesting that, particularly in cases of complex foregut and hindgut emergencies, a specialist surgeon can improve the outcomes. But this doesn't extrapolate to all kinds of problems. For example, you don't need an HPB surgeon to deal with choledocholitis. Now, would you rather have a jack of all trades, master of none, taking call, or a master at one trade, disaster at the rest? I know what I'd like. In summary, subspecialists are special, and we should keep them well rested until we need them. But until that point, we got this. Thank you for your attention.
Thanks, Walt. I'm going to give Dr. Margulies a couple of minutes for rebuttal, and then you will have the same opportunity.
Could I have my slides continued? So I laid it out for you. I gave you the reasons. And again, you heard the other side. And Dr. Biffle, you know, who could doubt him? I mean, he's world-renowned trauma surgeon. He's well-published. He's expert golfer. He's a connoisseur of wine. You know, so of course he's going to try to confuse you with those statistics he listed. Some papers, and so really, you know, who could doubt him? But I was looking at this picture, and you know, it's got an orange tie. That's a little different. So again, you know, he gave you these arguments. So I was starting to think about why he was wearing that orange tie, and I give you the rest of the picture that he was starting to show. He showed me, he showed Shanu, but he's wearing orange pants in this picture. And I was just wondering, what's up with that? And so I just did a little reconnaissance. And when we went to this place, this is what he drove up in. This is his car. And so he's definitely got something going on with orange. And so I sent a drone out to see what kind of a house he lives in. And lo and behold, again, it's orange. So, you know, now this, I was starting to wonder, you know, why is he having such a thing? And this is what I found out. This is actually his twin brother. He's a golfer that, and you can see the resemblance. They both have brown eyes. And they both like orange. So this golfer and Walt apparently are twin brothers. I went back and found the records, and then I confronted Dr. Biffle with this. Well, why do you hide from having your twin brother who always wears orange? Why do you not tell us about this? And all he could say was, well, I'm not coming to the meeting. So apparently, he wouldn't answer, and he wouldn't come to the meeting. And so if that's the case, how can you believe anything he says? Furthermore, I found out that when talking with his brother that, you know, when they were young trying to play golf, his brother told him he golfs like he's hitting a wiffle ball. And in fact, Fowler used to be his name, and now he changed it to Wiffle, and that subsequently became Biffle, but that's just how he got his name. So back to him, I don't think you can believe anything he has to say. And I go back to my original arguments. I think that we're in deep trouble if we don't have the general surgeons taking call that know how to take general surgery call. And I'll end there. Thank you.
Dr. Biffle?
Well, my secret is out. And I will say I love orange clothes and I like my orange car. So there. What I didn't hear in Dr. Margulies' rebuttal is anything having to do with the topic. And I think that gets back to my comment that I think he's in agreement with me that we should have the people taking calls who know how to take care of the problems. And I will leave it at that.
All right, we have a few minutes left for questions from the floor, or I can provide some questions to stimulate good debate. And I'll lead with a question for Dr. Biffle. A lot of this question is how you frame it. We have an echo in here. You know, you frame the question as, do you want someone who's a jack of all trades taking care of you versus someone who has a narrow subspecialty but isn't very good at taking care of the condition you have? For many communities, it's not that question. The question is, do you want someone who's a trained general surgeon, or do you want no one at all? And so how do we address that? Because I think in the big academic centers and in the big cities, you probably frame the question correctly. And, you know, at our institution, we trauma acute care surgeons do virtually all of the emergencies. And it's a good system for our department so that our elective surgeons can focus on elective things and we can handle it. But a lot of places don't have that level of resources. And so the places where it's a question of nobody versus a trained general surgeon who did an MIS fellowship or a endocrine fellowship, I think somebody's better than nobody. Is that wrong?
Let me answer that as well. And that's right. That it's analogous to, I mean, what do you want to do on call? It's really covering the nighttime coverage. The daytime, there's plenty of people that can take care of the problem. So it's really covering the night. And an analogy is the orthopedic surgeons. And they really don't, you know, they all got trained in how to take care of fractures, but there are those that really are good at it and those that are, you know, just trained in their residency and are now specialized in shoulder or joint. But there aren't enough to be actually in-house all the time taking care of it. So they have this panel of people that can basically, you know, stabilize the fractures, do what's needed when on an urgent basis, and then the more complex things get done during the day by the team. That's orthopedic. Similarly, you know, this can work for general surgery where you don't have to be doing the laparoscopic common duct exploration during the night. You do what you need to do and you get those patients prepared, and then the team that's most expert will take care of them in the days. But it does provide the coverage for urgent things that need to happen at night by people that are trained to take care of it. And so this is really a manpower issue. And I think the solution is not to go the way we've gone, but to allow the people that have been trained to continue to practice their training.
I think that Dr. Den had directed the question at me, and I, you know, to answer that, first of all, I addressed the question the way it was raised, but what you're talking about, Dr. Den, is, you know, those non-university hospitals or rural communities, and you've probably got an audience full of people who practice in those environments who could talk about what it's really like. I could say about 20 to 25 years ago, when acute care surgery was being discussed, I had to do a debate at the Denver Academy of Surgery about it. And people were getting to me saying, you're just talking about general surgery. That's exactly what acute care surgery is if you add in trauma and critical care. University hospitals aren't the issue here. And if you're out in a rural town, then that's what general surgeons are doing. They're taking care of all of it. I think you probably have a small number of surgical subspecialists in rural communities, and I don't know what it's like there, where the option is to have a general surgeon or nobody. I don't know how many of the subspecialists you'd have in those environments to enlist them. But I think fundamentally, you know, what I've said, and I didn't even bring up the breast surgeons that Dr. Margulies did, but I worked in a place where the chairman mandated that everybody take general surgery call. And when that breast surgeon did a gram patch that failed and then took him back and redid it and it failed again, that convinced me, if somebody's not doing this stuff, it's hard to go do it in an emergency. So I'll leave it there.
All right, Dr. Singh was next.
Yeah. Charlotte, North Carolina is a fairly urban area, but 20 miles outside, we get very rural very quickly for hundreds of miles. So there's a lot of critical access regions within that. I guess the question in those areas is how are we going to train those people? And should we begin to think about a particularly different tract of general surgical training to be able to cover those issues, not particularly acute care surgery, but maybe the ability to at least stabilize damage control and then refer pretty much like we do our level 3 trauma centers, bringing them to the level 1s. Just curious your thoughts.
Well, I mean, I'm not sure if you're suggesting further training of the acute care surgeon. That's what they do essentially. And some do that fellowship. But the point is that the residency of general surgery trains folks sufficiently well to basically to take care of those things that can happen at a community level. And this has happened for many, many years where the small communities, the general surgeon is doing it all. What's happened now is that they're having to do more of it because the specialists won't. And I'm just saying that if you add the specialists to the pool and they stay in practice without having to do a whole lot, it just decreases the amount for any one particular individual, shares the burden of call, and then in the daytime, the person most appropriate can take care of the patients.
I think what I understand you're referring to, Ron, is a more rural area where the surgeons will be called upon to take care of things that they don't see commonly, maybe some high acuity things. And I think that this gets back to the way the residents are trained. And what Jerkovich referred to, that study from the American Surgical, it was pretty alarming how fellowship directors were looking at their new fellows fresh out of training saying, a third of these people can't do a lap chole by themselves. What if they were going into practice in a small town? That's a problem. So I think we got to go back and look at the way the residents are being trained, the amount of autonomy that they're getting, because that's how you learn. And I know that times have changed. You can't let a third-year resident and an intern do appendectomies unsupervised anymore, but we've got to find a way to get residents fully trained and battle ready, as it were, during those 5 years that we have them.
I'll just also say that paper and that talk that Jerkovich gave was really railing on that terminology of saying, I'm not comfortable with this, as an excuse for not doing it. And basically saying we shouldn't be allowing that, to say that it gives you an out. And I don't think, those that have actually been trained should be allowed to be saying that. So I'll stop there.
Yeah, Dr. Kathari is at the microphone,
Yes,
probably to defend himself.
a little bit. So I've really enjoyed this debate and important topic. Then there's the flip side, Walt, which is I know you would dabble in elective foregut surgery, and that's a separate issue whether you should be doing that or not. But when it comes to call, there's call frequency and there's call intensity that has to be factored in as well. And when I met Walt at this meeting, and we are still friends, I said, how often you take call? He says, one day a week. And then I said, well, just what I was doing. And then he said, I said, well, what do you do the other 6 days of the week? And he said, recover. And so I think the question that I'd like to hear people comment on is the elephant in the room is the post-call time. And that's where I think some of the challenges where models are set up where you go home as opposed to you go back to work. And I think I'd like to hear what some of the comments are around that, because I think that's where one of the challenges are that causes some civil unrest amongst departments as well.
Yeah, and that's a whole debate in itself, but I do think that, you know, the residents have been mandated to do that. They have been trained to not work after call. And that was for many reasons, and all of you are familiar with it. And I think now the residents that get finished are used to that. And so that has to be the attending's role in the future. That's what they're expecting. That's what they're used to. And I think we need the manpower to allow that on a humane level. We never got trained that way, and we don't do that, but we need to move towards that. They shouldn't be expected to work after spending, you know, a night on call. So we're going to need enough manpower to allow that. And that, again, has to do with spreading out the number of calls by increasing the pool. And that's one of the ways to do it. And if you have enough people taking call, then the frequency is going to be reduced, and you can allow that. But that is going to be the future. This is how the residents are trained and what they will expect when they are attending.
Shanu, I think, you know, you raised an important issue there, talking about dabbling in elective surgery. I am not in a place where I can dabble in things electively anymore because of the fragmentation, because of the, you know, patient's ability to choose their surgeon. Nobody's coming to me for foregut surgery. Nobody's coming to me for colorectal surgery, except you know, the fistula and ano I saw in follow-up the other day. But that is more of a problem for the ability to do emergency surgery. You know, in my training and early career in Denver, it was, you know, emphasize that if you're going to do something in an emergency setting, you've got to be able to do it electively. You got to get some practice. And if you're not able to do things in the light of day in a controlled setting, but then you're the one on the hook at night to take care of it, it does make it harder. So if subspecialists aren't going to take primary call, they've got to be available to help. Like the, you know, the papers I showed, the colorectal and the foregut, you know, those are gastric emergencies. It's important to have good help because you can do the patient some harm if, you know, you haven't done that operation in a long time. And now here they are with a hole in the stomach. That's where the patients get compromised. So we've got to find some medium, you know, making sure people are well trained, but also having the right help or a way to get help when they need it.
All right, we're at a point where we need to wrap up. I will say that the point Dr. Singh brought up, the American Board of Surgery is moving toward all entering residents that start July 1st, 2023 will have to prove competency in a variety of entrustable professional activities before they graduate. And so moving to a competency-based training model should address some of the concerns that were raised by that Matar article that both of you quoted from the American Surgical. And proof of those competencies should then allow you to take call and be comfortable doing so. I also like to mention Tim Nelson, one of our Southwestern Surgical members who couldn't make this meeting, in his presidential address to the Association of Program Directors in Surgery, pointed out that one of the things we need to do in surgical training is we need to train people to be comfortable being uncomfortable. And that's not happening in the, you know, highly mentored hand-holding model of let me teach you how to do a procedure, as opposed to let me challenge you with a case and see how you think intraoperatively and how you handle challenging situations that require changing thought paradigms even throughout the course of the care of that patient. And so hopefully the competency model will help with that as well. But getting people to be comfortable being uncomfortable, I think is one of our challenges and something we need to embrace. And Dr. Jerkovich's talk referred to that as well. So any last second comments from anyone? All right, well, thank you all. We'll move on to the next debate.
Maybe I'll make the last comment that when I was being forced to go off of general surgery call as a surgical oncologist, my parents were visiting. My dad was a general dentist his whole life in a 5-person practice, private community practice. He took every 5th day and every 5th weekend call his entire career. And they were visiting, and I said, oh, I have to go to a meeting tomorrow to argue that they're trying to kick me off of call. And my dad said, I'm sorry, you're going to the meeting to fight to stay on call? And I was like, oh my gosh, you're right. I'm not going to that meeting. And I stopped taking call. So I have the privilege of introducing the debate interval appendectomy. You have an emergent patient that gets a drain. Should we take their appendix out afterward or not? Dr. Bjordahl is a general and acute trauma care surgeon at the Sanford Medical Center in Sioux Falls, South Dakota. And Dr. Mulwini is a general surgeon at the Altoview Hospital in Sandy, Utah, a suburb of Salt Lake City, both community or non-academic, I believe. Sanford is academic. General and trauma critical care surgeons. So we'll start with Dr. Bjordahl on the argument of yes, we should do the interval appendectomy.
Well, thank you, and thanks to the program committee for the invitation to participate and an opportunity to come and violently defend a position and ignore all studies that I disagree with my bias. So we're going to talk about, I have the easy side of this debate because I'm trying to convince a room full of surgeons that appendicitis is actually a surgical disease. And we're going to see it's obvious. And so what we're talking about is a so-called appendiceal mass. And that's this. You get the CT scan, and this is not your simple early acute appendicitis. This is the difficult to approach, no tissue planes, may or may not have an abscess that needs to be drained. And if you go in and you operate on these immediately, the patients oftentimes get sicker instead of better. And so historically, those were managed with an immediate appendectomy. And there's trials still being enrolled in the last couple of years and published, comparing non-operative management plus an interval appendectomy with just immediate appendectomy. And so we're really taking historical data from those trials and trying to estimate the incidence of recurrence and what's the best timing of appendectomy. But interval appendectomy has been the standard of care that they're comparing all those things to. And like I said, they're comparing the immediate versus the delayed appendectomy. So when they take that historical data with very little prospective data, they've appropriately questioned, is there a necessity for that interval appendectomy? But those are based upon cases of uncomplicated appendicitis recurrence rates and looking at comparisons of immediate versus interval appendectomy that are really not asking if you take the appendix out, but just when. So I have 6 obvious statements to support this, okay? But I have no disclosures, not even from hotels.com. So number 1, retrospective studies are flawed. Captain Obvious knows that. That's why we go to all the trouble of making prospective randomized control trials. They have a poor definition of recurrence. They don't really have a clear definition of the initial diagnosis. Some have imaging, some have physical exam. There's enrollment issues. There's an inherent selection bias. And in the end, we're trying to draw conclusions where we're analyzing data that's not intended to answer our question. Okay. Interval appendectomy is safe. I think likely every general surgeon in this room has done that. That's not the case you see on the OR board in the lounge and strike up a conversation about, wow, you're doing an interval appendectomy today. Big day. Complication rates are relatively low, generally under 10%. Most commonly, it's a wound infection. It's effective. Take out the appendix, they never get appendicitis again, unless you don't take out the whole appendix. So the timing is the debate, not the efficacy. Recurrence is bad. It's what we're trying to avoid. And that seems almost too obvious to say, but we're gonna show some prospective data that shows that complicated appendicitis recurs with complicated appendicitis. And so you can't really just take a statistical equation and say how many appies were done in each group, because the recurrence is worse than the interval appendectomy. Recurrence is frequent. Our prospective data we're going to look at says probably about 1 in 4 are going to have a recurrence within that first year, oftentimes complicated. And so you got to stop and think. If you had an acute appendiceal perforation, or your child had an acute appendiceal perforation in April, and you had a 25% chance of having another perforation this year, how do you feel about booking those tickets to Maui? I think we're at least going to get the insurance on those airline tickets. And lastly, adults grow cancers. And sometimes appendectomy is the only diagnostic tool we have to pick up those neoplasms. So I'm going to look at some of the flaws of some of our retrospective data. And you can look online and find any recurrence rate you want just on Google Scholar. And as Abraham Lincoln said, if it's on the internet, then it must be true. Okay. This is one of the often cited studies, retrospective meta-analysis trying to estimate recurrence rates. Total of 1,400 patients in the observational group. This is presented at our sister organization, the Southeastern Surgical Meeting in 2014. All comers in their 1,400 observation patients, they said recurrence rate's only 12.4%. So you need to do 8 appendectomies just to prevent 1 recurrence. So we sure about that. And if you go and you pull all the source papers from that, you'll see that actually most of those patients were in an interval appendectomy group. More than half of those observation patients had an appendectomy. So it's not a bad study. It spurs conversation, but it's not a practice changer. It just gives you an idea what to study next. So on to the next points. Interval appendectomy is safe, it's effective, and recurrence is not safe. Prospective randomized trial done in children called the China study. This is out of Europe and New Zealand. Took 100 children after non-operative management of acute perforated appendicitis, and they randomized to either interval appendectomy or observation. After exclusions, they did 44 interval appendectomies. 2 lap appies were converted to open. They had about a 1-day length of stay. They had 2 wound infections, and they did have 1 port site hernia. Take that with their observation patients. In the first year, about a quarter of them had an appendectomy. They broke that down a little bit more in that histologically, they only considered 6 of them to be an acute recurrence, although 5 of them were clinically recurred and had chronic inflammation. Of those 6 acute inflammatory cases, 4 of them either started or converted to open. They had a wound infection, a prolonged ileus, 1 reported scar cosmesis issue. 1 little girl had her fallopian tube inadvertently removed with a specimen, and they had about a 5-day length of stay. So while the authors didn't specifically report on whether or not these were complicated recurrences, the complicated nature of those recurrences argues that there were challenges with at least half of the recurrent appendicitis cases. So interval appendectomy was done to prevent recurrent complicated appendicitis, and in the observation group, they got more recurrent complicated appendicitis. What do you think was going to happen? Another study, Tanaka, and publication in 2016, very pragmatic prospective trial. Patients and their parents could opt for either immediate appendectomy, delayed interval appendectomy, or just observation. And people who opted for observation still had a 34% recurrence rate, more than half of them complicated, starting right back at square one. So for children, that conversation regarding risks and benefits of observation, maybe a 25% chance of getting appendicitis again this year versus your scheduled interval appendectomy is at best complicated, but should be offered. In adults, Eastern Association for the Surgery of Trauma tried to tackle this a couple of years ago as part of their adult acute appendicitis guidelines. They were really only able to find 3 studies that addressed acute appendiceal perforation. They had, again, about a 25% recurrence. They really didn't have enough data to comment on complications or length of stay. And so based solely on the statistical recurrence rate, they gave a conditional recommendation against routine interval appendectomy, despite what is very clearly preventing recurrence. However, they did give the disclaimer that acute appendiceal perforation can be the initial presentation of malignancy, and it must be mindful of that. This brings us to last point, that adults grow cancer. Last year at SAGES, a group from Seattle gave their retrospective look at interval appendectomy specimens after complicated appendicitis, found an overall neoplasm rate over the age of 30 as at least 11%, and that got progressively higher with age, upwards of 40% over the age of 80. The periappendicitis acuta trial published in JAMA Surgery. This was the randomized control trial designed to show non-inferiority of my opponent's watch and wait approach with an interval appendectomy in adult patients. Primary endpoints, 23% of the observation group had a recurrent appendicitis and an appendectomy. Interval appendectomy group had a good safety profile. There were 3 infectious complications, all non-operative. However, at an interim analysis, this trial was terminated due to the high neoplasm rate in adults. All said and done, with their 60 enrolled patients, they ended up with a 20% rate of neoplasm, most commonly low-grade appendiceal mucinous neoplasm. By the interim analysis, a third of the observation patients had already had an appendectomy. They called them all back and offered them and recommended each of them get an interval appendectomy. Okay. Both of those last 2 articles are summarized in a meta-analysis that's in press, which again demonstrated for adults an 11% neoplasm rate. I believe that's over the age of 18. So why should we take out the appendix after non-operative management? Well, we thought that acute appendicitis with complicated appendicitis recurs frequently, and we thought that there's a risk of other misdiagnoses, namely neoplasm. And when we reviewed pretty well done prospective data, we found out that complicated appendicitis recurs frequently, and there is a risk of those misdiagnoses. So for acute complicated appendicitis with a phlegmon or an abscess after successful non-operative management, an interval appendectomy is safe, it's effective. A recurrence is worse than an interval appendectomy. Adults have a high rate of associated malignancy, and oftentimes that's only detected with an appendectomy. There is not a good screening protocol for early low-grade mucinous neoplasms. And high-quality data to support omission of interval appendectomy is really lacking. So the answer to the debate is yes, we should offer interval appendectomy. And I will give some fine print, absolutely in adults over the age of 40. For younger patients, there's definitely a risk, and I believe it should be talked to, at least in a risk-benefit setting. Thank you.
Good morning. I'm Mark Mawhinney. As mentioned, I'm a general surgeon in Salt Lake City and pleased to have the chance to speak with you this morning. If we are calling this up, thank you. So this is my hospital here, Altaview Hospital, and it's a community hospital associated with the Intermountain Healthcare System. And we sit right at the base of the Wasatch Mountains there. So my office is 3 miles from the mouth of Little Cottonwood Canyon, which for you skiers in the audience is home to Alta Ski Resort and Snowbird Ski Resort. And it's 4.5 miles from the base of Big Cottonwood Canyon, which is Solitude and Brighton Ski Resorts. And I live basically in between those canyons, just at the base there, but take too much call to spend as much time in the mountains as I would like to. But my kids get to have a great time skiing all winter long. So Dr. Bjordahl did a fantastic job presenting his side of this discussion. And this is an important question about whether we should be offering interval appendectomy after non-operative management of complicated appendicitis, with or without drain placement, with phlegmon or with abscess. And I enjoyed looking into this and preparing for it because it really is a question and a practice that can be argued on both sides of the spectrum. You can be on the wrong side of the argument, or you can be on the right side of the argument. And hopefully we'll come to that conclusion here by the end of this session. It is, though, one of those instances where it is important to discuss the pros, the cons, and the potential drawbacks and benefits of either decision with your patient in counsel and really come to a decision together. Yesterday in our morning session, Dr. Copps did a great job presenting non-operative management of appendicitis in general. And we're going to dive a little deeper now into the topic of interval appendectomy after non-operative management in the complicated scenario. So I want to walk you through a scenario, and this is something we've all seen and you're very likely to see in your practice, particularly in our current climate of healthcare. And this is a 25-year-old male, otherwise healthy. He developed vague lower abdominal pain. He had some mild nausea, anorexia, and after a day or two, his pain localized to his right lower quadrant. Pretty straightforward story. His nausea progressed to vomiting. He thought about going to the emergency department, but remembered seeing on the news that hospitals and the system was currently overwhelmed with COVID patients, and he didn't want to be a drain on resources or put himself at risk for contracting COVID. So he stayed home several more days, actually felt better for a day or two, and finally, after a week or so of symptoms, decided to come to the emergency department after he developed persistent fever and recurrent abdominal pain. On presentation to the emergency department, he was tachycardic but normotensive. He had an elevated white blood cell count. He had tenderness in his right lower quadrant. And he went on to have a CT scan that's represented here, showing appendicitis with a fairly sizable associated abscess. Surgery was consulted and recommendations were made, appropriately so, to admit this patient to the hospital, start broad spectrum antibiotics, and consult our interventional radiology colleagues for drain placement. That was done successfully, as you see represented here with the drain in the abscess cavity. He responded well to treatment, was discharged from the hospital several days later, and a follow-up CT sonogram showed that the abscess cavity had resolved and the drain was removed in the surgical clinic the following week. The recommendation was then made for the patient to go on to have a laparoscopic interval appendectomy. Dr. Beardall will be pleased. That was performed uneventfully. He was discharged as an outpatient. The pathology was benign. This is where the plot thickens. A few days later, he comes back to the emergency department. He has abdominal pain, nausea, vomiting. A CT scan shows that it looks like the staple line at the appendicocecal junction dehisced completely. He was taken to the operating room for a washout ileocecectomy. His recovery was complicated by a wound infection requiring gauze dressing changes for several weeks. He came back to the clinic about a year later after he'd recovered, and he now had a sizable ventral incisional hernia. He says this has been a difficult past year for him, from hospital admission and drain placement to appendectomy to ileocecectomy to wound infection, and now to this sizable hernia causing him distress and symptoms. He then asked the million-dollar question, did I really need to have my appendix taken out? And perhaps after attending this debate this morning, you'll have a little more insight and maybe even a different answer than you would have prior to this morning. This is a common problem, as we know. This is not news to anyone else, but the most common abdominal surgical problem in the world. Surgery has been the gold standard for years. But there are special circumstances where non-operative management has been shown to be superior in the acute setting. And this is with perforated appendicitis with either phlegmon or abscess, the appendiceal mass, as was referenced earlier. Studies have shown decreased morbidity and improved outcomes when emergent surgery is deferred and non-operative management is instituted in this acute setting. Assuming that this non-operative management is successful, do we really need to go back and perform an interval appendectomy as has been standard or recommended for some time? So why the conservative management initially? Well, complicated appendicitis with perforation, phlegmon, or abscess is a different disease than early uncomplicated appendicitis. Again, multiple studies have shown emergent surgery to have increased risk of surgical site infection, overall complications, postoperative abscess, ileus or bowel obstructions, and a risk of intestinal resection ranging from 25 to 30%. So for all of these reasons, it's generally accepted that non-operative management is the treatment of choice for the complicated appendicitis. Most patients respond very well to antibiotic treatment with or without drain placement in this setting, with upwards of 90% of patients avoiding initial surgery and allowing for this inflammatory process to subside. So there's really three big arguments for why to perform an interval appendectomy. Dr. Beardall did a great job presenting those. The reason or the concern for recurrent appendicitis and missed pathology, such as neoplasm or inflammatory bowel disease, are considerations. And certainly patient concern or anxiety about missed pathology or recurrent appendicitis plays into that decision as well. Well, we'll see in just a minute that recurrent appendicitis can be managed safely if it were to happen. Large reviews have shown the risk of missing or delaying diagnosis of cancer or inflammatory bowel disease to be approximately 2%. And we have other modalities available for detecting neoplasm or inflammatory bowel disease, such as interval CT scanning or interval colonoscopy. And after you attend this discussion this morning, you'll be able to assuage patient anxiety because you'll know so much more about this topic. Traditionally, interval appendectomy has been recommended because of the concern for recurrent disease. Multiple studies have shown that risk to be quite low. Some of the more recent studies showed a titch higher than it's been, but 5 to 10% on the historical data, upwards of 15 to 20% more recently. If you recall from our discussion yesterday, the lifetime incidence of appendicitis in general is somewhere between 7 and 10%. So the risk of developing recurrent appendicitis in this setting, similar to the risk of developing acute appendicitis in the population in general. The most commonly cited reason for recurrence would be the persistent presence of an appendicolith or a fecalith. And those patients have been shown to have a higher risk of recurrent appendicitis after non-operative management. And studies have also shown that it's safely to manage recurrent appendicitis with repeat non-operative management, or if now in the second setting amenable and favorable, they can be managed surgically with laparoscopic appendectomy or drain placement if now amenable in this instance. Additional studies have shown the morbidity of interval appendectomy, as was referenced earlier, to be approximately 11%, thus justifying the need for interval appendectomy solely based on the risk of recurrent appendicitis, somewhere in that 5 to 10 to, if you want to round way up, as Dr. Beardall did, to 15 to 20%, justifying the morbidity of interval appendectomy with the risk of recurrent appendicitis. They're basically equivalent to one another. And it's probably not justified based solely on the risk of recurrent appendicitis. Patients with a persistent appendicolith may benefit, of course, because they have been shown to have a much higher risk of recurrent appendicitis in both uncomplicated and complicated appendicitis managed non-operatively. The risk of missed pathology is where the debate and discussion really does get tricky. I think it's fairly clear that the risk of recurrence is not justification alone for performing interval appendectomy, but this is where the nuance really comes into play and a lot of discussion has to come into play. I'm presenting my side as fairly black and white, but acknowledge there are definitely some gray areas to this topic, and there might be certain patient populations that would benefit from a little different treatment strategy or surveillance strategy than other populations. So many early publications that recommended avoiding interval appendectomy cited the low recurrence risk, as stated on the last slide, and they also quoted the low overall risk of neoplasm in appendectomy specimens in general. That rate has always been quoted as somewhere between 0.7 and 1.7%. So call it a percent chance of having an underlying neoplasm in appendectomy specimens in general. Recent studies, as was mentioned, have shown that the rate of appendiceal neoplasm in patients undergoing interval appendectomy is certainly much higher than that. And a large systematic review with a retrospective cohort of over 13,000 patients with acute appendicitis again showed the overall neoplasm rate to be about 1%, in line with traditional numbers that we've always quoted. But in patients that had this inflammatory mass, that rate actually varied from 10 to 29%. This especially held true in patients that were over 40 years old. And as Dr. Beardall mentioned, the recent randomized clinical trial looking at appendiceal neoplasm that was published in 2019 showed a very high incidence of neoplasms, where the study population as a whole showed a rate of 20%, and the rate in patients over 40 was in fact 29%, and all neoplasms in that study were seen in patients over 40 years old. So as he mentioned, they actually stopped that study early, prematurely, because of those numbers that they came across. Similar retrospective review published in the American Journal of Surgery in 2015, looking at almost 6,000 patients who underwent appendectomy over a 12-year period. A couple hundred of those were managed or treated with non-operative management, and about half of them went on to interval appendectomy. Neoplasm similarly discovered in about 12% of those patients. Mucinous neoplasms and carcinoids were the most common. The rate of neoplasm in patients over age 40 was higher at about 16%. So that patient population does need to be treated differently. Agreed. But I would argue they don't all need interval appendectomy. They need dedicated follow-up with interval colonoscopy and CT scan. The patient population under age 40 appears to be at a much lower risk. Inflammatory bowel disease is uncommon but possible underlying etiology. And in one large systematic review, it showed about a 0.7% chance of patients having an important benign disease, such as Crohn's disease, detected during follow-up. It's unlikely this diagnosis would have been missed for a prolonged period of time, or a delay would cause significant harm. And the majority of patients treated for this condition are already diagnosed with CT scan. So treatment in the acute setting, inflammatory bowel disease, will really not differ much from the appendiceal phlegmon or mass. Antibiotics and drainage are, if feasible, are typically performed. Close follow-up with interval colonoscopy can be performed, and imaging, if symptoms persist or recur, can always be performed. It's important to counsel the patients that these are certainly possible complications, though. So I think the most appropriate treatment strategy for these patients is initial non-operative management with antibiotics and drain placement if feasible. As mentioned earlier, studies show an increased risk of morbidity and complications with immediate surgical treatment. Initial non-operative management is very successful in over 90% of cases. About 20% of patients qualify for drain placement. And after successful non-operative management, close follow-up is needed to ensure that symptoms have resolved. And patients over the age of 40 may need to be referred for follow-up colonoscopy or follow-up CT scan. So to summarize my recommended treatment strategy for complicated appendicitis with drain placement, antibiotics should be instituted, a drain should be placed if possible, the patient should be seen for close follow-up. If symptoms have resolved, then we move on to this risk stratification, like every other surgical disease or surgical clinical decision-making strategy. Regardless of the patient's age, I think if they had an increased risk of recurrence from a known appendiclith, they would benefit from an interval appendectomy. If they do not have a high-risk feature for recurrence, I would stratify them based on their risk of malignancy. If less than 40 years old, they're at a lower risk of underlying malignancy, and they would not need any further workup for this. If they're older than 40 years old, I would recommend follow-up colonoscopy and CT scan to rule out neoplasm. If none is seen or suggested on those studies, the patient would not need any further follow-up and would not need interval appendectomy. This treatment strategy addresses the three commonly cited historical reasons for recommending interval appendectomy, including recurrence, neoplasm, and patient worry or anxiety. And it's also completely in line with the 2020 Jerusalem guidelines, which were just updated in the World Journal of Emergency Surgery, that quote, recommend against routine interval appendectomy after non-operative management for complicated appendicitis in adults younger than 40 years of age and children, recommend for recurrent symptoms, and suggest colonic screening with colonoscopy and CT scan if greater than 40 years old. So in our clinical scenario, our young man was at a low risk of recurrence. He was at a low risk of neoplasm, and he did not need interval appendectomy. Of course, I took a few liberties and stacked complication on top of complication in this scenario, but we've all seen these situations where that one patient is put down a path of continued complications, and this young man would have avoided that. Thank you.
In rebuttal, Dr. Viardel?
I guess rebuttal just specific to the follow-up for patients over the age of 40. I think it's important to know that the most common malignancy you're going to find is a low-grade appendiceal mucinous neoplasm. There's not really a well-defined screening protocol for that. And even in the periappendicitis acuta trial, which I'm trying to click to here, Of those patients they called back, they called back an additional 10 patients who underwent interval appendectomy after they terminated the study. And they found after the patients had already undergone a follow-up colonoscopy and a follow-up MRI, they found 2 more neoplasms in those patients that had already passed through the screening protocols, because there's not really a good way of finding an early low-grade acute mucinous neoplasm. So for many of these, the interval appendectomy is really the only good way to find them. But really with regard to the children and the people under 30, I don't know if I have a specific, they have to have an interval appendectomy, but knowing that if your 25-year-old came back with a recurrent perforation, he needed a drain, and now he's got a fistula and he needed an ileocectomy, and then he had all those complications anyway, we'd wonder why we didn't take it out with a 1-hour operation that sent him straight home.
Thank you.
Thank you.
Dr. Maloney?
So again, this is a fun discussion because there is a lot of nuance to it. I also like that I got to present the side that I traditionally have not come down on. And I learned a little bit about it. And I think now I will have more of a discussion. Traditionally, I nudged patients towards interval appendectomy because I felt like I could deal with the problem. I wasn't going to miss something, and I like to operate. Now, after reviewing all this data, I would feel much more comfortable selecting patients that I would not operate on and that I would follow up with just screening studies. We have to be stewards of healthcare, particularly in this climate. We have to be stewards of resources. And one way we can do that is treating a population as a whole and deciding where are the higher risk patients and who absolutely needs the resources that we have and that we can provide. So there's not a perfect answer to this, but I think the high-risk patient over 40, that patient with high-risk features of recurrence, that the recurrent patient needs to have surgery. The patient that's over 40 needs to at least have follow-up studies to rule out neoplasm. And there's a lot of gray area in the younger population. And hopefully we'll learn a little bit more. The randomized study that came out, the authors critiqued their own study saying this was a small sample size. We didn't reach our desired endpoints because we had to stop it early. So we'll see if there's some even longer term follow-up or larger scale studies that might answer this question better for us. But thank you, and thanks, Dr. Bjordahl. Thanks, Dr. Skay, for asking. Be happy to take any questions.
Thanks, Chris. Are there any questions from the floor? I'll start. Unfortunately, Dr. Bjordahl, I'm going to pick on you because I'm a surgical oncologist. And so I'm wondering, I have a 2-part question. One, is there any evidence that an earlier diagnosis, your slide said it was an early diagnosis, but it's a perforated neoplasm, so it's not an early diagnosis. Is there any data that in this patient, an earlier diagnosis changes their prognosis? And particularly for these LAM patients, is there any data that the appendectomy changes the approach for the future HIPEC surgeon?
That I'm aware of, no, I don't think there's data for either of those assertions. The authors in one of the studies did cite that, by not operating on those potential neoplasms immediately, perhaps it's a little more contained in its own perforation rather than you going in and freely doing it with immediate appendectomy. But otherwise, no, I don't have any support of that, knowing it's already perforated, as you pointed out.
Dr. Dent?
Yeah, so 2 questions. First one is just a point of clarification. The term appendiceal mass, I hear that, I think, a mass in the appendix itself, not a periappendiceal abscess or phlegmon. And the patient with appendiceal mass is not a candidate for non-operative management because that appendix needs to come out and you need a pathology specimen. Am I wrong with that interpretation of that term?
I think the term is kind of a throwback to the days when they didn't have a CT scan for every appendicitis. And so it's somewhat of diagnosed appendicitis and you're physically feeling a phlegmon or an abscess. It's the palpable finding.
Fair enough. And then the other question is, I've approached these patients, my communication with the patient, my communication with the residents that are helping me care for this patient is, you tell the patient and you plan for interval appendectomy, and you create that expectation in everyone's mind. And then at the time you're seeing the patient back in clinic, you sit and thoughtfully review whether or not that seems like the right idea. But I find that a lot easier than dealing with a patient who was told in the first hospital stay, you won't need your appendix out after this, and then the pathology report comes back, or a follow-up CT or whatever shows there might be a mass in the tip of the appendix, and now you've got to shift gears toward appendectomy. I find it easier to shift gears away from it if you create the expectations on the front end that they will all need an interval appendectomy, and then you can decide later not to. Is that a reasonable approach?
Is that working? Yeah. So I think in the acute setting, it's harder to explain to the patient why you aren't operating. Agreed. They come in with a perforated appendix with a phlegmon. Most patients hear appendicitis and they assume they're going to have surgery. So for me, most of the conversation initially is explaining why we aren't going directly to the operating room. And I explain the increased risk of having to convert to an open procedure, possible intestinal resection. So the goal of this acute setting is to get them through the infection, make sure that's dealt with. And then when we see them back in the office, we'll talk about options for managing your appendix long-term. So I've just noticed in my practice, most patients need to be not sold on, but explained as to why you're not just taking their appendix out like their neighbor had who went home 3 hours later. And I explained this is a different animal where you have the potential to receive a much bigger surgery. And then when we get them through that, we meet in the office and talk about how do we now manage your appendix. And that's worked well for me.
I'd agree. I like that approach because as Mark pointed out in his talk, we're not only managing recurrence risk and malignancy risk, but it's anxiety as well. And that's probably a good approach to help with that.
Thank you.
Dr. White?
Hey, can you put up Paul's slides again?
While we're doing that, if I might ask Dr. Mawini a quick question. Chris, can we have Dr. Bordall's slides again? Dr. Mawini, when
Just to
You
go
are-
forward or backwards. Just go.
when you're advocating for surveillance, what is your CT scan frequency and interval? How many scans for how long? How often do these patients need surveillance?
Undefined.
Stop,
Um,
stop.
So I typically would refer them for colonoscopy 6 to 8 weeks after symptom resolution. And that would be a reasonable time frame to scan them as well. You want to make sure the inflammation is subsided, so you're getting the best picture possible. But that time frame hasn't been delineated in any sort of prospective study that I came across. It's all author recommendation.
Dr. White?
Great question, though.
Thanks, guys. That was very enjoyable. And we learned in the first debate that Dr. Biffle has an unknown evil twin. And I was just wondering if you had something you wanted to disclose to us, Paul.
That was actually, the picture of him in his swimming trunks was actually my photo.
I tried to do some background on Dr. Bjordal and maybe years down the road, we can have more of the banter that Dr. Biffle and had. But I pulled up his reviews on his website and they were so glowing that I quickly closed my browser and said, forget it. So that wasn't going to work.
So I have two broader questions. My first question is, this debate was specifically set up that the patient has an abscess and had a drain. If you had a patient who is treated in the British style, you have early appendicitis treated with antibiotics only, would you offer an interval appendectomy in that patient? Mark?
In uncomplicated appendicitis?
Uncomplicated appendicitis treated with antibiotics alone.
Boy, that is a whole nother session that we had yesterday. So those recurrence rates are very well defined now, based on 1, 3, 5, 7-year follow-up. And I think those rates have been shown to be higher, upwards of 40% or so at 5 years, because they are different diseases. And I think, no data to back this up, that in the uncomplicated appendicitis, it gets better with antibiotics. The appendix is still intact, and it still has the potential to reinfect through the same process it did before, some sort of luminal obstruction. And I think when these appendixes are blown wide open with a perforation, you've probably obliterated it to the point that you're not going to get recurrent appendicitis as often as with the uncomplicated. That's my own opinion and just having thought about it a lot. So I don't frequently offer non-operative management of uncomplicated appendicitis, to be fair. I typically offer surgery. And until we have, there's a couple of reasons, if you don't mind me taking the time. In those early studies, the patients were mandated to have inpatient IV antibiotics for upwards of 3 days in some of those studies. The patients had open appendectomy, as we all know. If we can get an uncomplicated appendix out in an hour and they go home a few hours later, I have a hard time selling that to a patient in today's world. So until the study's done, like we have in diverticulitis, where we can send people from the emergency department home on oral antibiotics and know that that's safe, I probably won't change my practice. That would be the big fork in the road for me, is knowing that I'm justified with data in just giving them a prescription for Levaquin and Flagyl and seeing them in the office in a week or two. That would be the big change for me, but we don't have that yet.
Paul?
Well, I guess I tend to take the appendix out when it's uncomplicated as well, but there's the occasional patient, maybe they just had a PE and they have appendicitis as well or something. It's not safe to operate and you get away with non-operative management. The benefit in the non-perforated appendicitis is that they tend to recur uncomplicated as well. And so they come back in and they get it out and they more or less have their interval appendectomy when they have their recurrence. And I think that's where many of the recommendations for no interval appendectomy come from, is that the outcomes aren't any different if you come in with a recurrence or come in for your interval.
Any other questions from the floor? So I'll ask the real world question. We know that there are flaws with randomized controlled trials. We know there are flaws with retrospective data. And so there are big organizations now looking for real world data. So you all kindly agreed to do this debate and were assigned your topic. And we appreciate your participation and your excellent preparation and presentations. But you have a 25-year-old with the abscess that you showed, Mark, in the beginning of your slides. What are you really going to do?
I'd offer him surgery
Huh?
in a delayed setting. Yeah.
No, I would likely do the same.
Thank you. We have a break now. There's a break till 10:30. Please visit our sponsors. There's tea and coffee in the next room with the sponsors. And